Good day, everyone. Thank you very much for joining us today for the 18th AFOMP School webinar on redefining theranostics in nuclear medicine in the era of precision oncology. Today, we have a panel of eminent speakers to speak on different aspects of theranostics in nuclear medicine and its aspects related to precision oncology. So today's webinar is being moderated by Associate Professor Kitiwat Khamwan. He is currently working in the Division of Nuclear Medicine, Department of Radiology, Faculty of Medicine in the University, Bangkok, Thailand as an Associate Professor. And he holds many positions in the national and international medical physics associations and organizations. He is the member of Professional Relations Committee of AFOMP also, actively contributing to the monthly webinars and other activities of Professional Relations Committee. He has many awards and honors in recognition of his outstanding research and professional and academic activities. He has more than 25 index publications and many book chapters, and he is a constant presence in most of the international and national conferences of medical physics. With this introduction, I would like to request Associate Professor Kitiwat to proceed with the further proceedings of today's AFOMP School webinar. Over to you, Professor Kitiwat.
All right. Thank you so much, Mary, for your kind introduction. And good afternoon, good morning, good evening, everyone, for all of the medical physicists in Asia-Oceania region. So my great honor to host this webinar for the AFOMP School webinar for the August episode. So for this episode, we will focus for the theranostic in nuclear medicine. So all right. So again, I'm Kitiwat Khamwan from Chulalongkorn University. We'll be serving as the moderator for this session. And today for the AFOMP webinar school for the August episodes. So we have the three honor speakers to join us. So the first one is Dr. Associate Professor Dr. Shiratori from Department of Radiology, Faculty of Medicine, Sirilat Hospital, Mahidol University. And the second one is Associate Professor Dr. Deni Hardiansyah from Department of Physics, Faculty of Mathematics and Nature Science, University of Indonesia, Indonesia. And the last one is Assistant Professor Dr. Tippayamontri from Faculty of Allied Health Science, Chulalongkorn University, Thailand. So this is the, I would like to thank all of the speakers to join us and will be giving the wonderful lecture to us today. All right, so let's start from, and three of our speakers already with us today. So, and then let me start from the first speaker for the first topic. Okay. Yes. Okay, for the first topic will be given by Associate Professor Dr. Shiratori. Okay, you can share your slides.
Yes, thank you. Yes, can you see my slide?
Yeah, we can see. Yes, all right.
Nice.
Let me introduce a little bit about the background of the Dr. Shuichi Shiratori. Dr. Shuichi Shiratori, he got a bachelor degree from the Faculty of Pharmaceutical Science, Chulalongkorn University, Thailand, and then got a master degree from School of Pharmaceutical Science, Chiba University, Japan, and PhD in Pharmaceutical Science in the same university, Chiba University, Japan. He served as the Associate Professor at Department of Radiology, Faculty of Medicine, Sirilat Hospital, Mahidol University, Thailand. And his expertise are in the radiopharmacy, radiology, oncology, and neurology. So he will deliver a talk regarding for the theranostic in the era of personalized radiopharmacy. Okay, if you're ready, you can start your talk now, Dr. Shuichi.
Yes. Good afternoon, distinguished colleagues and ladies and gentlemen. First of all, I would like to sincerely thank the organizing committee for inviting me to speak at this webinar. And I would like to show my appreciation to Dr. Kitiwat for nice introduction. So this is the truly honor to join such a distinguished seminar and to meet the experts in this area. So in this few minutes, I will share my experience on title Theranostics in era of personalized radiopharmacy. In highlight some of the most recent advances and perspective in radiopharmacy that are shaping our field. I'm looking forward to exchange the ideas and learning from all of you during these sessions. So let me start. I would like to close my video during my speech because I don't want to see my face on the screen. Thank you. I have no potential conflict of interest relevant to this lecture. Okay. First, let I introduce the Theranostics. The Theranostics has a long history starting from the radioiodine. As we know, we use the iodine I-133, 134, and 135 for imaging, and we can use the iodine 131 for the treatment. This is the original concept of the Theranostics. And the Theranostics are combined two words together. The first one is therapeutics, and second one is diagnostic, as the same words. The concept of Theranostics is very simple. As you can see in this picture, we can see the shadow of this camel is reflect the concept of Theranostics. That is, we treat what we see and we see what we treat. We treat what we see means we need to see to imaging, especially the cancer where it is. And then after we detect, we can treat. When we treat for some cycle, like a 2 to 4 or 6 cycle, we can monitoring or evaluate the result by imaging again. So we can see what we treat, I mean the result. This concept are under the is a subset of the personalized medicine. For example, in this scenario, when we have a group of the cancer patient, we can imaging, and the result will show the positive group and negative group. For the positive group, this is possible to go further in theranostic approach. But for the negative group, yeah, we can back to the conventional therapy. And the personalized radiopharmacy is aligned to the personalized medicine as a sub and subset. So right now we are dealing with 2 types of cancer. The first one is neuroendocrine tumor, and the second one is prostate cancer. So the radiopharmacy will be tailor the specific radiopharmaceutical for each patient, direct to them, not for everyone. And we use the 2 types of radionuclides. The first one, the first purpose on diagnosis, we will use gallium-68 or fluorine-18. For the therapy purpose, we use 2 types of radionuclides. The first one is beta emitter as a lutetium-177, and next is alpha emitter as actinium-225. With this radiopharmaceutical concept, we can go further in the detail. I would like to start from neuroendocrine tumor. This is the first tumor that we are focused in Theranostics. The neuroendocrine tumor are unique groups of the malignans that growing arise from the neuroendocrine cells. The symptoms of this cancer are not specific. Right? For example, we have the pain in abdominal pain, have a cough, diarrhea, or fatigue is really normal symptoms. And one important characteristic is a low incidence. We found this type of cancer less than 10 in 10,000 population. But luckily, we have a specific target on neuroendocrine tumor because we found the somatostatin receptor overexpressing in this type of cancer. Most of them are located about 40% in the intestine and stomach, and another 30% in the lung. So altogether, most of the incidence will fall in these organs. So as a somatostatin receptor overexpressed, we have an idea to use the antagonist of somatostatin. This shows the somatostatin hormone as a prototype to develop the radiopharmaceutical. We mimic this somatostatin hormone composed of 14 amino acids until 8 amino acids in the cyclic. And then we can various this position, the position 1, 3, 6, and 8. And then we fix this amino acid. By this method, we can have a wide list of the radionuclide. I mean, the ligand for we can various the ligand for radiopharmaceutical like this. So right now we focus on the octreotide as a main purpose because the receptor, somatostatin receptor have 5 subtypes, 1, 2, 3, 4, 5, and octreotide can bind to the main subtype. Let me show the really first case of lutetium dotatate for neuroendocrine tumor in Thailand. This case happened when I was in Chulalongkorn University. The patient is 33 years old, female, with a pancreatic neuroendocrine tumor grade 2 with a liver and abdominal lymph node metastasis, as you see in this imaging. You can see the 2 large tumor mass. The first one on the left-hand side, this is about 1/3 of the size, I mean the body one, very huge one. And the next one is located along the main blood vessel. So in this case, the surgeon will refuse for operation because once we cut, this very risk to bleeding, overbreeding. So because the limitation of the option treatment, this case come to our department to start the Theranostics. We start the first cycle, and then we continue for 4th cycle. This is the result. You can see the size of the left one is shrinking, smaller but still exists. But the good thing is the tumor around the main vessel was already disappeared. And this is really good result because we can send this patient to the surgeon. The surgeon can operate to remove the less cancer. So next, let me move to the prostate cancer. Prostate cancer is somewhat opposite characteristic to neuroendocrine tumor because This is the second most common cancer incidence in the worldwide. The luckily point is the early diagnosis become very important topics recently, and it's possible to be cured, to treat, because we can find a specific receptor on prostate cancer. The receptor name PSMA stands for prostate specific membrane and antigen. So this show the PSMA ligand that's specific to the PSMA receptor. In the market, we mostly use the PSMA 11 for diagnosis and PSMA 617 for treatment, because we have the same ligand in the yellow circle here. It's another type is PSMA INT. INT stands for imaging and therapy. You can see this is the same chemical structure of the ligand to bind to PSMA receptor. With the PSMA INT, we can use both imaging and therapy. I would like to show our first case in prostate cancer as well. This case is 62 years old with the CRP castration-resistant prostate cancer. That means they are resistant to every standard treatment, starting from hormone therapy and radiation and chemotherapy, and also the surgery. So no standard treatment can stop this cancer, and it's already metastasis to the bone and to the liver. This is the first cycles imaging after injection lutetium-177, because lutetium-177 is 90% beta emitter, and about 10% it can emit gamma. So that's why we can imaging this patient after first injection. So what we found here, we found a very large lesion on the shoulder, on the right side, also left side, and also the knee. So at first, this patient come to us on the wheelchair because he cannot walk, and this shows why he cannot walk, because it is really huge pain on the knee, both sides. And you can see the metastasis to the spinal cord, and also here in the liver. After one cycle, the interval dose is 2 months. After 2 months, he walked back to us, and he told us that, okay, thank you so much, because he feel like he's younger 10 years than 10 years. So I just joking to them that, okay, we inject radiopharmaceutical to you. We did not inject Botox. So why you feel 10 years younger? So the patient answered that his everyday life from past 10 years returned back to him. For example, he can start walking. He go to golf. He can do almost activities that he did in past 10 years. So that's why he feel 10 years younger. And he is looking for the second dose injection. Okay, and we start injection. After that, the scan results can show here. You can compare to the left-hand side imaging, for example, for the shoulder and for the knee. So this is strong evidence that why he can walk, he can do every activity like the past 10 years. And you see at the spinal cord. And the tumor mass in the liver also shrinking. This is only one injection, one dose for very, very first case of us in prostate cancer. So let me show another one. When I was training in a short course in Germany, let's use the actinium-225 tagging to PSMA. This is the result. This is the late state of the patient have already spread bone metastasis almost everywhere on the bone, and these are 3 cycles of actinium PSMA. The result can show here is very clear. Actually, when I was there are many some patients can be treated with actinium PSMA. I select this case to show you, to emphasize its efficacy and the safety, because you can see here that this patient got only 1 kidney. With the only 1 kidney, the creation of actinium-225 PSMA can be excreted. Okay, so right now in Thailand, we continue these 2 types of cancer, neuroendocrine tumor and prostate cancer. So we think about the next step. Not only we, the many researchers around the world also think about the next step. For example, the lung cancer, we can do this, or we can apply this approach to the lung cancer. The answer is yes, but it took the time, because we need to find a specific receptor and specific ligand to bind. What same to the last previous cancer types. But how about this one? We need not to do that, but we find something new that radiopharmaceutical can bind in the range of the tumor. This concept sounds interesting, and let's see, does it work? Before the answer, I would like to introduce the cancer-activated fibroblasts. In the tumor mass, we have the special condition called micro environment of the tumor. In the tumor mass, this doesn't mean all the tumor, it's composed for all the tumor cells, but in fact, it's composed of the tumor cell and another cell. This is not tumor. For example, epithelial, local fibroblasts, and marrow cell, and many cells. But these cells are activated to be the special fibroblasts. That's we call fibroblast activation. This become the special fibroblast that's different from another fibroblast in the body. On this cell, we will find the fibroblast activation protein that is overexpressed on the tumor. So this become the target for us to use the specific ligand to bind to the fibroblast. So the new concept are emerged by not binding to the cancer cell. Instead, it binds to the fibroblast that activated by the cancer cell. We found this specific receptor in many solid types of cancer. It's more than 20 types of cancer right now that we can find. And then we decided a specific molecule to bind to this receptor. So the new one, the new series of radioligand called FAPI. FAPI stands for the fibroblast activation protein inhibitor. More further, this FAPI can be developed in many versions. So I would like to introduce you the first version for FAPI-02. This is like a prototype in this series. The FAPI-02 can be labeled with the gallium, lutetium, and actinium. So the radionuclide will bind to the DOTA in this position. Next, next version is FAPI04. FAPI04 can also attacked by gallium, lutetium, and actinium too, because it's the same DOTA, and moreover, there are two Fourier atoms in this position that we claim the more efficacy. The next version is FAPI33. FAPI34 is suitable to bind with a Technetium-99M, and you can see the same ligand with a different type of chelator. The next one is FAPI46. FAPI46 was claimed to be more potent because this position was changed from FAPI04. And with the DOTA, they can bind to the gallium, lutetium, and actinium as well. For the last version in this series that we can see in many literatures is FAPI74. With the FAPI74, this can be by only the gallium-68 because the chelator is not DOTA, but it's just NOTA. Let I show some result from this series. This is example of gallium-68 FAPIs. You can see only one single radiopharmaceutical can use in many solid types of tumor. For example, the sarcoma, esophagus, the breast cancer, cholangiocarcinoma, lung cancer, colorectal, head and neck, pancreatic, and COP, ovarian, yeah. And this result are emphasized on the efficacy of the FAPI, and the FAPI become very, very interesting ligand right now. But unfortunately, we try to get the FAPI from the original source. Right now, the patent is held by a company in USA, but we cannot find the original FAPI marketed in our region. So I cannot show you the result because I cannot get the FAPI at this moment. But more advanced to this FAPI small molecule, there's another type of FAPI right now. This is the name is lofapitide. The common name, like a nickname is FAPI2286. As you can see, you can see the chemical structure that totally different from the previous one. The previous one is small molecule, but this is the cyclic peptide that chelated to the DOTA. This consists of the 7 amino acids and claimed as enhancing the binding stability and tumor retention if compared to the previous series. These FAPI2264 are developing and will be on the market by a famous pharmaceutical of the world. So I skipped to tell its name. So this new one will become and can be marketed in many countries in next few years. Moreover, we have an alternative to lutetium-177. Lutetium-177, as we know, that there's a very useful and reliable and widespread in Theranostics. And right now, the new one, the new radionuclide, terbium-161, is coming. So let I compare for the information. I compare the property of lutetium-177 to terbium-161. With the half-life, you can see this about 6 days. Yeah, it's not so different. For the emission, lutetium-177 emit beta and gamma, but terbium will emit 100% beta with the HL electron. HL electron is the new point of interest in our field. For the beta range, is almost not significant different. For the therapeutic range is also not so different, but the difference is application. The application of the lutetium, as we know, is the first line treatment in Theranostics. But for the terbium, it's better than lutetium, only the point of micrometastasis, because of the AJ electron can deliver the energy in very, very short range. So this is very good to the micrometastasis that lutetium-177 cannot do it. Recent publication support this idea and this concept of the terbium-161. This shows the first human of terbium DOTA-TOC. This is used for the neuroendocrine tumor, as you see in part A, B, and C. The part A is a coronal section and sagittal section and transverse section. You can see the binding of the terbium DOTA-TOC very clearly. This can be compared and can be alternative choice of the lutetium-177 with the micrometastasis benefit. The next one, this is very new publication. This just published last month. The first in human of the terbium PSMA, and it's quite interesting. You can see the detail in this reference. Okay, in summary, the Theranostic in personalized radiopharmacy marks a new era in precision medicine, where the diagnosis and therapy converge to serve the individual, not average. And by integrating the target radio tracer, adaptive dosimetry, and molecular imaging, we will move closer to treat the right patient with the right radiopharmaceutical in the right time. And I hope this information will be useful for medical physicists to work as a team in Theranostics. Thank you for this is my presentation. Thank you.
Thank you very much, Dr. Shuichi, for your nice presentation regarding for the radiopharmaceutical use in Theranostic currently right now. And it's like we have a new radiopharmaceutical in Theranostic coming out. Yeah. And well, for those who have any question, you can leave your question in the chat box, and then we will have the Q&A session after finish all of the speaker. Okay, thank you very much again, Dr. Shuichi, for your nice.
Yeah, thank you, Dr. Kitiwat.
Okay.
Okay.
All right, so let's move to the next speaker. The next speaker will be Associate Professor Dr. Deni Hardiansyah from University of Indonesia. And before we start his presentation regarding for the optimizing dosimetry in radiopharmaceutical therapy using machine learning, PBPK, and NLME models, so let me introduce a little bit about the background of Dr. Deni. So Dr. Deni, he got a bachelor degree in physics from University of Indonesia, and then got a master degree in physics in the same university. And then he got a PhD in medical physics from Heidelberg University from Germany. And Dr. Deni, he published several papers regarding for the second time point dosimetry and relevant paper in high top-ranked journal like Journal of Nuclear Medicine and European Journal of Nuclear Medicine and Molecular Imaging. He got several grants, for example, like Asian and Oceania Young Investigator Award from Japanese Society of Nuclear Medicine this year, the first winner of Tomoe Oino Award from Asia Oceania Congress of Nuclear Medicine and Biology Conference last year in Bali, and international based abstract at the SNMI conference last year in Toronto. Yeah, he got many awards. All right. So, and right now he serves as the associate professor at Department of Physics, University of Indonesia. If you're ready, you can start your presentation now, Dr. Deni.
Okay, thank you very much for a very kind introduction, Kitiwat. So let me start the presentation. So yeah, ladies and gentlemen, so it is an honor for me to be one of the speaker for today's webinar. And then in this webinar, I will deliver the topic of optimizing dosimetry in radiopharmaceutical therapy using machine learning, PBPK, and NLME model. So this is the outline of my presentation. So we will discuss together about the general overview of tuck fitting, prior knowledge in radiopharmaceutical therapy, some introduction, for example, for the physiologically based pharmacokinetic model, population-based pharmacokinetic model, machine learning, and also some example of implementation of all of this modeling technique to improve dosimetry in RPT. Okay, let's start with the first one, tuck fitting. Okay, before we discuss further about the dosimetry itself, maybe we can ask one very important question, whether the dosimetry is important at all. And actually, there are many publications already show a dose-effect relationship for absorbed dose in molecular radiotherapy. So it means that giving different dose can lead us to different effect for the outcome of the therapy, as shown by Strigari et al. Yeah, so in this very nice paper, she show different types of paper showing this dose effect relationship. And as you can see, with the different threshold and so on, we can also have a different endpoint for the effect. So that's why, again, this show that dosimetry is important. And actually, in 2016, our team also show that the fixed dose method is not very good based on in silico study. As you can see here, the x-axis is the TR root, the y-axis is the TR prediction. If we are not giving the calculation individually, then the result would be not so good like this. But if we calculate it individually, the result would be very, very nice between the prediction in treatment planning and the true. The TIAC, by the way, is also correspond directly with the absorbed dose. So therefore, from this slide, we can say that dosimetry is needed for an optimal delivered dose to kidneys and tumor. But the next question is how to do dosimetry to determine the injected activity. So this is how we can do treatment planning in RPT. So first we can start with the quantification of patient-specific pharmacokinetics, and then we perform parameter estimation, prediction of pharmacokinetics during therapy. Then after that, we can use this result for calculating the absorbed dose by adding radionuclide data and also mass and location of organ. Perform therapy planning if possible. Then we can also add some radiobiological information. Perform the treatment planning. After that, then we can perform the treatment itself and perform some QC measurement after the treatment. And then if we need to do it several times for different cycle, then we can have a cycle of this treatment planning step as well. And if you want to discuss this in more details, then we can imagine we inject the patient and then we ask the patient to perform several imaging steps. And then after that, from each of the imaging step, we will have different image. And then we perform quantification of the image. And then after that, we perform modeling. And then we can calculate the area under the curve. And then at the same time, we can also perform the simulation for the transport radiation inside of the patient body using, for example, in this case, some phantom, virtual phantom. Then we can calculate what we call as the S value. And then we can combine all together these two steps with the MIRD scheme, with this equation. And then after that, we will get some prescribed dose. For example, we would like to have the tumor absorb dose as maximal as we can. And then for the constant, for example, we have the kidney absorb dose to be less than 23 gray. Then after that, yeah, we use all of this information to calculate the administered activity for the patient treatment, and then we perform the treatment. And then, one of the most important part of the treatment planning is the tuck fitting. Why? Because it was published in 2018 by Javereva that 90% of inter-individual variability of the absorbed dose is affected by the tuck fitting. As you can see, we have two terms here, right? The first one is the tuck fitting, calculating the area under the curve of the time activity curve. The second one is the S value calculation. And then, of course, which one that we need to individualize, right? And this paper showing us that if we are not individualizing the tuck fitting, then we will have an error, a very high error, 90%, because this tuck fitting can really explain the difference of the absorbed dose in our patient population. So that's why from this slide, we learned that it is very important to individualize the tuck fitting. But how can we perform tuck fitting? So this is the general overview of the tuck fitting itself, published by our team in Physical Medical last year. So in general, we have 4 steps. So the first step is the collection of the data required for the fit. We call this as the data input. And then after that, we also need to define the model of function that we can use to model the change of organ activity with time. And then we can call this as function input. So this is number 2. So number 3, we can combine data input, function input all together in the fitting concept itself. And in this third step, we have actual processing of the data and the definition of underlying uncertainty. And we call this as data processing. And the last part is selection of the data required for presenting the result of the fit or the data input. And then it was published as well by Mas et al. That adding prior knowledge to the tuck fitting function input and data processing could enhance the accuracy of the calculated absorbed dose. So we would like to have a very accurate and a very good calculation of the area under the curve of tuck, right? In this tuck fitting steps. And then it showed that prior knowledge can help. So that's why let's move on to the definition of the prior knowledge itself. What is the prior knowledge? So the prior knowledge itself is all prior information about the subject of interest and or the drug parameter that could be added to the treatment planning steps, in this case, tuck fitting process, to enhance the accuracy of absorbed dose calculation. In this case, prior information can be the body weight, body height, physical decay, biomarker information, and etc. So this prior knowledge, how we add it to the step of the tuck fitting itself, we can add it to the model structure. And in this case, then we deal with the physiological-based pharmacokinetic model. The second one is we can add it to the fitting process. Population pharmacokinetic model can be used for this. And last but not least, we can also use machine learning to explain the unknown relationship of the parameter. So that's why in the next slide, let's discuss together one by one about all of this technique that can help us to add the prior knowledge into our tuck fitting process. So the first one is the physiological-based pharmacokinetic model. So by definition, PBPK model is a modeling technique for predicting the absorption, the distribution, metabolism, and excretion, or people also call it as ADME, of a drug or a labeled drug in humans and animal species by incorporating physiological information. So the prior knowledge itself in this model structure is the information of the physiological and also the drug parameter. And then we can add all of this into physiological model framework. And then, as you can see here on the right side, it means that we model the whole movement of our radiopharmaceutical drugs inside of the patient, from the blood moving to the organ, distributed, excreted, and so on. And then after that, we can get the in vivo information about the biokinetic. So why we need PBPK model? Because first, it is the framework for integration of in vitro data. We can perform priori prediction of PK. Kinetics in tissue or effect compartment can be estimated. So you can imagine that we have also the PD for the dose effect relationship, right? We can also build it and add it all together to the PBPK model as a whole digital twin of the patient. We can also perform extrapolation across species, route of administration, and doses. We can also perform modeling of subpopulation, for example, obese patient, elderly, and so on. So this is one of the advantages of using PBPK. So you can imagine, because when we build the model, we specifically define the physiological parameter, right? So that's why when we build the model for certain population, and we would like to convert it into other types of population, we can do that by changing the physiological parameter. So it's quite straightforward. And last but not least, it is also important, that we can also model the variability and uncertainty. And the key feature of this PBPK model is the predictions. And to my knowledge, the first such PBPK model in nuclear medicine was published actually a long time ago, 2009. So it's quite long. And PBPK model can be used for developing a digital twin of a patient. The next one is, let's discuss about what is population-based pharmacokinetic model. Population pharmacokinetics, or POPPK, is the study of pharmacokinetics in the population of interest and data from all individuals that are modeled simultaneously. And POPPK is also a very old concept, and it was introduced in the early 1980s by Schenner, Bell, and colleague. So it's a very old method. And right now, POPPK is an integral component in regulatory application for drug marketing approval, as it summarizes pharmacokinetic data obtained across many phases of drug development. So this POPPK is a very important concept in drug development process. The area where POPPK has made a large impact, again, is in the drug development. And because this concept is very, very important, so you can imagine, if you would like to create new drug in America and you would like to send the report of your drug to the FDA, then one of the requirements that you need to do is the POPPK analysis. So you need to have the result of the POPPK analysis for your submission of the new drug administration to the FDA. And because, again, this concept is very important, FDA even granted its own guidance in 1999. And a population pharmacokinetic approach enables comprehensive analysis of pharmacokinetic data from diverse study design, including sparse, dense, and mixed dataset. And as you can imagine, it is very beneficial then for our community in nuclear medicine, right? Because most of the time, our data are sparse. Some of the clinic, they have 3 data, some of the other, they have 5, some of the other even, they only have 1 or 2. So the benefit of this POPPK is the ability of adding all the data together, fitting all the data simultaneously. So the prior knowledge here is the sharing information between one patient to another. So patient with a very less data can have some information from the patient having more data. So therefore, POPPK is helpful when wishing to identify factors also that affect drug behavior or explain variability in the target population. So these are several advantages for non-population pharmacokinetics. It means that usually people, for example, if we use software like commercial software or Olinda, right? So we fit individually. To the best of my knowledge, I haven't seen any software with population kinetic modeling implemented inside. But yeah, fitting individually it has some advantage. For example, relatively small number of people are required, or patient in this case. Sampling design is often fixed, but it has some disadvantage. So for example, pharmacokinetic variability between individuals is confounded with variability in the estimate of parameters such as clearance, and often cannot screen and quantify effect of covariate. And of course, in the term of the accuracy, it is not that accurate because we cannot add the prior knowledge from other patients to our individual fitting process. But if you perform population pharmacokinetic, we have many advantages. For example, only a few samples are needed from each patient. Screening and quantification of covariate for explaining variability is possible, and also can distinguish between inter-individual and intra-individual variability. Although there are some disadvantages. One of the disadvantages is because this concept is quite complex and needs some expertise. But once this method is already implemented in the software, then I think this problem is gone, because the user doesn't have to know all the complex things inside of this method. It is similar like ChatGPT, for example. For us as a user, it's very easy to use it, right? But actually inside is a very, very complex. So it doesn't mean that complex method, we don't want to use it because it's complex. But if it's already implemented in a software and we all believe that it's important, then in the future, it would be easy to be used clinically. So nonlinear mixed effects modeling, by definition, is a population-based estimation method that can be used to identify drug disposition in the term of intra-individual variability and inter-individual variability. And from this slide further, I will always say NLME, in addition to the POPIK, because actually NLME is the most commonly used method for the POPIK method. Although POPIK method having two different methods, two-stage and NLME. So intra-individual variability is actually the way we explain the variability of the measurement that we have, in this case, biokinetic data. And inter-individual variability, it means we would like to explain the variability, the difference between one parameter to another. For example, maybe the uptake rate or the clearance rate of one patient are different with other patient, right? And then how we explain this, by explaining it with the inter-individual variability. So for example, in this case, somatostatin receptor density in the kidney of patient 1 are different with patient number 2, and so on. Then we can explain this by using this inter-individual variability concept. And this is how we perform population PK approach. We have the input as population data set. We also have the model as the population model with the structural and statistical. Here, the structure can be PBPK model, by the way. And then for the process, we have estimation procedure. And for the output, we have the estimate of the model parameter. We have the model parameter in the population level and also in the individual level. We will also have some variability from the inter and intra. And if we want, we can also have some covariate effect. And the goals is to get the information of the exposure, safety, and efficacy relationship. And we can say the main purpose is to estimate the model parameter as precisely as possible and to define the precision of the parameter estimates. So last but not least, let's discuss and introduce about the machine learning, especially for the RPT. So what is the machine learning itself? So actually, machine learning, we can cite this statement from Herbert Simon. So learning is a process by which a system improves performance from experience. So the definition of the machine learning itself, if we cite Tom Mitchell in 1998, then actually the machine learning itself is the study of algorithms that improve their performance P at some task T with experience E. So we can have a well-defined learning task that given by P, T, and E. So what is the difference between machine learning and traditional programming? So for traditional programming, we have the data, we have the program, we add it all together in our computer, and we will have the output. But for the machine learning, we have different method. So we have the data, and we already have the output. So we add it all together, this data and output, and see the relationship between the data and the output itself. And then after we have the program that's showing how the relationship between the data and output can be explained, then this program can be used for further data, for another data from the next patient in this case. And if the question is, when do we use machine learning? So we can use machine learning when human expertise doesn't exist. Human cannot explain their expertise. Models are based on huge amount of data. And the most important thing is model must be customized. It means that if we want to perform individual dosimetry, then machine learning can be used. So beneficial for RPT treatment planning because we can use machine learning to explain unknown relationship of the parameter, output parameter from our tag fitting process. So after we discuss about some introductory concept of these different methods, let's go deep into some example of implementation of all of this technique in RPT. So first, let's discuss the first example for the PBPK model implementation in RPT. So this is actually the first publication of PBPK model in nuclear medicine in 2009. And these are all the compartmental model built with physiological base for explaining the anti-CD45 antibody radioimmunotherapy. So as you can see here, basically we built many compartments for different organ. For example, this is for the blood, main plasma. We have spleen here, we have liver, we have GI, we have also lymph node, red marrow, and other part for the meta. And then after that, we also need to explain that we have two different types of species here. The first one is radiopharmaceuticals, and the second one is pharmaceuticals, right? And they are both connected with the competition with the same receptor. So we can learn something from this publication. First, biodistribution of monoclonal antibody differ between pre-therapeutic measurement and therapy. So, we always make assumption, right, that if we have the biodistribution that we get from the pre-therapy, it would be the same with the therapy, but actually it's not. Why? Because the protocol and also the mechanism of the way we deliver the radiopharmaceuticals are different between pre-therapy and also the therapy. Why? Because of the different amount injected and also the monoclonal antibody injected for pre-therapeutic measurement. So they are different. So the amount are different, the activity are different. So usually for pre-therapy, we use less, right? For the therapy, we use more. So that's why we can perform the simulation where the x-axis is the unlabeled antibody and the y-axis is the target divided by the organ at risk ratio. And these are all for the 5 patients in their paper. And then as you can see here, this is what they gave to the patient, combination of the antibody, how much they inject in the therapy. But actually, based on this PBPK model, what they inject can be improved. For example, for this patient number 3, if we change the injection into around 25 milligram, then the result of the ratio between the dose delivered to the target to the organ at risk would be very, very high, like this. So all patients can be optimized individually. So optimal unlabeled monoclonal antibody amount improved by distribution considerably and depend strongly on the individual patient. So the second one is one of our publication in medical physics program. In this journal, we show that, okay, PBPK model, we have so many parameters, right? So that's why people tend to say, okay, we don't want to use this kind of model because we have too many parameters. And then the identifiability of the parameter is questionable. So that's why with this global sensitivity analysis, we can examine how the variability of the model output can be attributed to the variability of the model's input. So with this method, we can check actually which parameter, because each of the parameter in our population having their own distribution, right? We can see which parameter is the important one that can affect the uncertainty of the absorbed dose. So the aim is to identify the most important physiological parameter that have a large contribution to the variability of TIAC or absorbed dose using GSA and PBPK model. We use 13 patients with metastatic castration-resistant prostate cancer who underwent pre-therapeutic gallium PET CT and also post-therapeutic planar whole body scintigraphy after lutetium PSMA INT. And we use whole body PBPK model for this, and the input of interest is all the parameter that we estimated from the patient. And then one of the most important output from GSA is the main effect. So main effect showing an input parameter I represent the reduction in variance of the module output if the true value of the parameter I would be known. So you can imagine if we have this input in our PBPK model, and then this is the output, you can see that the absorbed dose having some uncertainty, as well as for that of the tumor. Then if we have X1 to be exact, then if we have SI to be 0.6 of 6 or 60%, it means that the uncertainty of the absorbed dose in the kidney can be reduced by 60%. And these are the results. So you can see that the calculated kidney absorbed dose in our population are very, different between one patient to another. As you can see, the CV is 31%. It means that if we perform the same fixed dose, we will have the possibility of an error of around 30%. So for the tumor, it's around 59%. And we can see here, some parameters are important and some of the parameters are not. Yeah, so for example, for the absorbed dose in the kidney, so the most important parameter is the receptor density and also the flow, blood flow to the kidney. But the other is not. It's not important. So that's why what we learn here, that individual dosimetry is needed based on this very broad distribution of the absorbed dose in our population. And the second one is reducing PBPK model parameter based on GSA, increase the data to parameter ratio, and improve the accuracy of absorbed dose estimates. So the next one is implementation of the POP-PK model. So the first example is about the population-based model selection for an accurate estimation of time-integrated activity using nonlinear mixed effects modeling. So what is the problem in our RPT dosimetry? One of the big problem, because we don't have reference, right? When we fit the data we have from the patient, we always, most of the time, people use assumption. Okay, so I have the data, so my assumption is monoexponential, for example, or B exponential and so on. So you can imagine different people with different opinion can lead us to different result of the dosimetry, which is not good. So we need to use a method that can be standardized so that different people can have the same result. So that is the aim. So that's why we need to perform model selection. So, but I understand the problem why people, for example, most of the time use monoexponential function, for example, even though it's already shown many times that this kind of function is not good. One of the problem is because we need to always obey the rule of the number of data need to be always larger than the number of the fitted parameter. So if we have 3 data, for example, then the maximum number of the data that we can fit is 2. So that's why monoexponential is the only option. So this is how POP-PK can help us. Why? Because POP-PK can help us to fit all the data together and increase the data to the parameter ratio. So that's why even though we have sparse data, for example, as you can see here, some patient having 3 data, some of the other having 5, having 4, and so on, but we can still nicely explain the patient with 3 data point with this population PK with a very good function that selected objectively, not subjectively, with the model selection. And if you can see here, patient number 6, if we use more exponential, the result of the area under the curve would be very, very different if we use this function from POP-PK analysis with the model selection, right? So that's why what we learn here, even if we check mono-exponential, the result is not very good, as you can see from the box plot. So the use of different function and fitting method could affect the value of the calculated time integrated activity, and the PBMS and LME modeling was shown to perform better than individual based model selection and PBMS with shared parameter that we published before. So as you can see, this concept is important, especially if we would like to create a reference model in our analysis. So the second one is from Sibinga et al. So this paper, the aim was to quantify the PSA dynamic after lutetium INT therapy, and they create a compartmental model, and then after that they also create a compartment to explain the PSA dynamic, as you can see here, and they connect this pharmacodynamic with the pharmacokinetic modeling part. And then as you can see, they could explain the relationship between the change in the PSA in the patient with the AUC. So this relationship is valuable for improving the dosimetry for individual patient. So how if we combine PBPK model with population PK? So this is one of our publication last year in GNM. So the aim was to find the best supported mathematical model to describe renal lutetium PSMA 617 biokinetic using NLME and population-based model selection, and perform single time point. And our study, in our study, we use a large data set of 315 SPECT-CT measurement and broad range of covered sampling times from 0.7 to 236 hours post-injection. So these are all the data information. You can read it in details in the paper. And then actually, as you can see here, first, the model that we use for the reference need to be very good. So that's why we perform POP-PK and also POP-PK and also the model selection. By the way, I'm sorry, I think the title is wrong. This is not PBPK and POP-PK. This is still POP-PK example. So we believe that one needs to use an objective method for defining the reference. Why? It can show a more accurate result, reproducible, and also systematic, because we can check different function and see which function that can better explain the data from our analysis. And basically, as you can see here, as a result, yeah, this is our method. This is Hardiansyah method, and this is Madsen method. Both of the method are frequently used method in the literature, and also the method that already implemented in the commercial software in the view of commercial software. But as you can see, our result is much better, yeah, than the Hardiansyah and Madsen method. So therefore, again, if you see that the result of certain method is good and so on for the STP dosimetry, so the question remains, so what type of reference they use? Because if they perform the STP dosimetry analysis with the reference of mono-exponential, for example, we don't know. Maybe it's good, maybe it's not. Because the reference, we don't know whether it's a good reference or not. And most of the time, again, it's shown that mono-exponential is not a good reference. So for the next one is the implementation of the machine learning. So this is the first example. Yeah. Publication by Gomez et al. Recently published in March 27, 2025. The aim was to introduce an instant STP method based on pre-therapy patient data, building on assumption that the T effective is a patient intrinsic characteristic, allowing flexible dosimetry with a single measurement during an early scan time point spanning from day 0 to day 3 after injection of the therapy. So this is how they perform the study. So first, they have multiple time point dosimetry using this function, where they have one clearance and one uptake, as you can see here. So they feed it and they say that this is the reference. And then after that, they perform single time point dosimetry using machine learning. How they perform this? So they have some feature, PET-CT data plus clinical data of the patient, and then they predict the effective half-life. And for this effective half-life, they predict only with monoexponential, so they don't have the uptake phase. And they also perform STP Hanchai method with this equation, and ISTP is just T effective. We predict it based on the machine learning. In this case, they use SVR method, and they derive the combination of different PET-CT and clinical data to see which one can explain the T effective. So the result look promising, yeah, because instant STP that they show, as you can see here, the red one is ISTP from machine learning, and the gray one is from the Hanchai method. And then they are quite similar, yeah, in 43, 69 hour post-injection time point for the STP. But ISTP is much better in the term of the first and the second time point they use, 2 hour, 20 hour post-injection. So they say ISTP achieve a significant mean relative difference, yeah, of the absorbed dose of less than 27% for the left and right kidney and liver. But actually we see some limitations. So the reference was chosen subjectively without any statistical testing, and the criteria of mean of the relative error of 27% might not be optimal. Because actually they choose this 27% because this is the maximum value they obtain from the analysis, and they say, okay, 27% should be okay. But then we perform our own analysis, but combining machine learning and population pharmacokinetic modeling. And this study is submitted to a journal. So the aim of the study was to find the best supported mathematical model to describe the biokinetic of lutetium PSMA 617 in the kidney using nonlinear mixed effects modeling and population-based pharmacokinetic model selection. And then after we have the best supported mathematical model, it means that we would like to have a very good reference model by using PBMS and LME. And then after that, to systematically evaluate and compare the accuracy of STP dosimetry method. In this case, we check 4 different types of STP method: NLME method, machine learning method, generalized additive model method that published by Wang et al. Recently, and also a hybrid approach that integrate NLME and also machine learning technique. And last but not least, to investigate the influence of the selected reference model PBMS and LME versus B exponential on the performance of STP dosimetry. But we are not showing this, by the way, in the sake of the time, because maybe the time of my presentation is not enough. So basically, these are all the method that we perform. So we perform the all time point fitting here to get a very good reference for the absorbed dose. And for the STP, we perform NLME plus machine learning for the hybrid approach, machine learning alone, and also the GAM method. And we calculate the performance by using relative deviation, MAPE, and also RMSE. And these are all the information of the data. And these are all the results. So as you can see, the GAM method is not that good because it is higher in all cases compared to all other methods. NLME and machine learning seems to be very similar, the result of these two methods. But if we combine both population-based pharmacokinetic modeling and machine learning, the result is very, very good. As I mentioned before, Gomez et al. Saying that, okay, the criteria of 27% is good enough for performing STP dosimetry, but we are much better than that. So the maximum of our result is 60% if we perform it at the first time point. So therefore, the combined method of NLME and machine learning provide the highest accuracy and predictive performance. So as a conclusion, the inclusion of prior knowledge in molecular radiotherapy could improve the accuracy of the absorbed dose. In this case, it is very beneficial for us if we can implement population pharmacokinetic, PBPK model, and also machine learning all together. The application of population PK and PBPK model in the dosimetry of targeted radionuclide therapy show great promise, offering the potential for more personalized and accurate treatments. Machine learning also has been shown to be a promising method to improve the accuracy of dosimetry in RPT. And actually, numerous studies have validated the utility of POPPK and PBPK. Machine learning, I suspect more to come in the near future, highlighting its strength in, but not limited to, accuracy, simplified dosimetry, and also pharmacodynamic analysis. And these are all the acknowledgements. So acknowledge the Dia Adi and also the Putih Q1 grant from my university and our collaboration with University and Freiburg University. I think that's all from me, Kitiwat. Thank you.
Yeah, thank you so much, Deni, for your wonderful talk regarding for the second half dosimetry, that based on your study, and also for the PBPK model, and also for the example of the machine learning. Yeah, that's such a wonderful talk. For those who have any question, you can leave your question in the chat box, and then I think Dr. Deni still stay with us until the end of the session. Okay, thank you so much, Deni. Yes. Okay, and let's move to the next speaker. The next speaker will be Assistant Professor Dr. Thititip Tippayamontri. So before we start her presentation, let me introduce a little bit about the background of Dr. Thititip. Dr. Thititip, she graduated from she got a bachelor degree in science with the second class honor degree in applied radiation and isotope from Kasetsart University, Thailand. And she got a master degree in radiobiology from University of Sherbrooke, Canada, and PhD in radiation science and biomedical imaging from University of Sherbrooke, Canada. And she pursued a postdoctoral fellow in radiation science and biomedical imaging from University of Sherbrooke, Canada as well. Right now, she serves as the head of the strategic research partnership in science sector at the Chulalongkorn University, and also the assistant professor at Department of Radiological Technology and Medical Physics, Faculty of Allied Health Science, Chulalongkorn University. And she will give a talk regarding for the exploring novel combined therapeutic strategy, external beam radiotherapy and targeted radionuclide therapy. Is such a very interesting topic. Okay, please welcome Dr. Thititip.
Thank you, Dr. Kitiwat Khamwan, very much for a very nice introductions, and also good morning, good afternoon, and good evening, everyone that joining to this webinar. And it's such a great honor to be a part of this 17th AFOMP School webinar. I think it's as myself is a radiation biologist, so this topics is and I'm work a little bit to radionuclide therapy as well. And today's subject that I bring to everyone is exploring novel combined therapeutic strategies and external beam radiotherapy and targeted radionuclide therapy. As I mentioned, for the view of radiation biologist, today my presentations, I would like to bring everyone to join me and discuss with me about the backgrounds about external beam radiotherapy or EBRT and what the radiation biology is behind the TRT, and moreover, and we would like you to bring together the discussions about the new technique, the advancement of this idea, and also the clinical implications, and moreover, how we gonna move forward for the next innovations regarding to the combined treatment. All right. So first of all, I think I'm gonna go quickly about the behind, what about the background knowledge of radiation therapies. So as we all know that for radiotherapy is the use of radiations with a high energy to kill the cancer cells. However, we need to maximize the energy to the cancer cells, but in the sense we have to aware that we have to minimize the as much as we can the dose to the healthy tissues. And for the EBRT, which is the differently for the TRT, right? And for radiotherapy as well, we plan to as close as possible for the personalized medicine in nowadays that we are concerned by telling the dose and also by looking for another technique like flash radiotherapy or adaptive radiotherapy. However, with the difference between the EBRT and TRT, before I move forward, we always say that to understand the biological behind, we have to know about chemistry. And also we have to know very well about the physics behind EBRT and TRT, which is totally different, all right? For EBRT and TRT, even though they bring to the effect to the cells, bring effect in terms of biological effect. However, both of them have individuals point of view or individual areas of effect that we have to be concerned. And also in this table that I bring to you here, for EBRT, we have to know very well the locations of where the tumor is to deliver a very high dose of radiation to the area that we have tumor. And by this one, for the biological consequencing, after treated with photons or electron, which is have a low LDT about 0.2 keV per micron, the biological effect mostly seen with acute effect with this high dose of radiation. And this radiation dose would be provided with the fractionation with multiple fractionations of high dose radiations. The strength of EBRT that everyone knows is the very precise, suitable for a bulky localized tumor. And also this EBRT can escalate dose to the tumor while sparing the tumor normal tissues. However, they still have limitations regarding to EBRT as well, because EBRT can treat only localizing disease where the tumor localizely. And this is limited for the widespread of micrometastasis. In this sense that we bring up everyone for targeted radionuclide therapy that we know as internal dose exposure. For TRT, we use the several of radiopharmaceutical compounds where Dr. Shuichi has been introduced to us earlier. The advantages of radiopharmaceutical compounds nowadays is advanced very much in the field of the diagnostics as well as in the field of therapeutics. And now the way of Theranostics that we are interested and we are concerned very much. And with this benefit of using radiopharmaceutical compounds, we can treat the cancer systemically. We can treat metastasis disease, and we can provide the personalized dosimetry as Dr. Deni has been talked to us just finishing. And this is the way that we're going forward in terms of treating our patients. However, with the advantage, there are also some limitations of a TRT. This is concerned in terms of the heterogeneous dose distribution regarding to the heterogeneous uptake of radiopharmaceutical compounds in each of the cells, which can show that in the hotspot or cold spots. This is regarding for the biology, they are showing difference of the biological effect. And also for the dose that we expose, we have a very such a low dose rate, and we provide is a continuous exposure. So this way, for TRT, we have to bring a lot of more concern in terms of a dose limiting of toxicities like kidney, bone marrow, or saliva gland. That is, we have to be concerned. And dosimetry, as Dr. Deni said, it has to be mostly be concerned for the dosimetry for TRT. In this sense, as for EBRT and TRT, we show that the aim of both way of treatment is aimed to destroy the tumor while sparing the normal tissues. But if I bring you for the TRT, for targeted radionuclide therapy itself, as today we are in the topic of the nuclear medicine, I would say that for the biological effects of TRT, we have to concern through several actions of our radiopharmaceutical compounds. First of all, there is a self-irradiations, and secondly, crossfire irradiations. And both of these self-irradiation and crossfire irradiation, we know as the targeted effects of TRT. But in this sense, in the new era of radiation biology, we're not just only concerned only targeted effect anymore. We look forward and look more clearly and deeply for the non-targeted effects, which is called bystander effect. Three of these targeted effects and non-targeted effects, we have to mix and totally concerned if we want to look for the total biological effect of TRT. Because all of either of them, cell irradiations, crossfire radiations, bystander effects, both bring different issues in the clinical implications. For example, for the self-irradiation, they have to be concerned for the heterogeneous uptakes of the radiopharmaceutical compounds, which is bring to different biological effects. And for the crossfire effect, we have to put very much concern about the isotopes that emitting from our drugs, which is beta or alpha, because we have to concern about the normal tissues that's nearby and can be irradiated from our drugs. And furthermore, bystander effect that is regarding for the non-targeted effects usually bring for the unpredictable biological effect, because we never know exactly what about the consequence of bystander effect will be shown off, because we don't know exactly when exactly it's going to be appear. Nowadays, it's not yet clear regarding for the bystander effect. So all of this can modulate, I would say it can modulate the response of the radiation to the cells, and can implement furthermore for the clinical outcomes after using TRT. Therefore, I would like to say how to gain the ideal radiotherapy in the sense of EBRT or as well as for the TRT. So as a biology, we have several things to be concerned. Furthermore, back to the principle of radiation biology, we look for the several R's of radiation biology. Usually we say 4R, 5R, but today I bring up to you about 6R. 6R regarding to repair, repopulations, radiosensitivities, reoxygenations, redistributions, and reactivations. These 6R concern can be involved as a factor that impact the biological effects of radiations. For example, for the radiosensitivities, this can bring back and bring forward also for the personalized medicines, because each of our patients have different of radiosensitivities regarding to their cells biology. So this is bringing up why we have to be concerned in terms of personalized medicine regarding for the dosimetry, regarding for the radiopharmaceuticals compound that we have to provide to our patients. And each of the radiopharmaceuticals that we have to concern, because each of them have difference of LDT and difference of RBE, which can be consequencing for the biological effect that are different. Moreover, if you're looking further, what about the technology that we have to provide? What about strategy to gain the idea of radiotherapy? We have to look for the precision delivery. How we can deliver the radiopharmaceutical compounds to be specifically to our cancer cells and not going to the normal cells. So we have to get back as a biology, we have to go back to the molecules of interest that are specifically expressed in each difference of the cancer cell types and difference of cancer patients as well. And moreover, we have to look for the strategy for adaptive radiotherapy to look about the real-time deliver the treatment to our patients. And moreover, in terms of biology strategy, as myself concerned, we're looking for not only radiation itself alone, the only modality that we provide for the treatment of our patients. We look for the combination treatment. Basically, usually we're looking for the combination with the radiation with the chemotherapy. We look for the radiations combined with the immunotherapy. But in this sense, in this kind of thing, another combination therapy would be interesting with the radiation with radiations. Usually people always think about radiation combined with the chemical compounds. But why not we combine the radiation with the radiations? The radiations itself, first of all, EBRT. External beam radiotherapy is all known is a standard of the cancer treatment, as I said earlier, and everybody agreed with that. And if we combine with the curative dose that we provided locally and with the dose that we can distributions with the spare the organ at risk, we can spare with different technique of EBRT. And in the sense of TRT, I said earlier as well, that it can specifically for the heterogeneities of those distributions and have different issues like crossfire and whatever. And if we can take the advantage of each one to limit the disadvantage of each modalities. So in this sense, if we can combine, I would like to bring you to this topic that I would like to say from now on, the combinations of EBRT with TRT. The combinations of EBRT and TRT here can show the characteristics of each of them. For EBRT here, we can say that it can be synergistically targeted to the tumor and distant micrometastases as we can have after the combined treatment. And also we can have the increased tumor dose due to the non-overlapping of the toxicities of EBRT and TRT. In this sense, why I bring it here, because some of patients, we cannot give too high dose of EBRT, and some of the patients, we cannot give too high activities of TRT. So if we can limiting the dose of each modality, our patients still safe, but effectively have the better of clinical outcome. In this sense, because of when we reduce the individual dose of each modality, we can reduce the side effects. That's why. And furthermore, nowadays that we are thinking and concerned very much to reach the Theranostics potentials, as our TRT can be diagnostic and therapeutics in the same time. Therefore, this is interestingly, I would like to point out one by one the rationale that some of you in the future might be interesting to use this in your clinical practice. Okay, in my point of view, as a radiation biologist, I bring up some operational combinations of ERT and TRT in this slide. I put everything in one slide because I want you to go through one by one with me. However, it maybe it's going to be small, but I'm sure some of this is kind of basic that everybody might know. And one thing that I would like to, first of all, here, the first rationale of combined TRT and EBRT that I would say, as you can, everyone here is the EBRT provides such a high dose of radiation to the well-defined of the localized tumor, where we know exactly where the tumor is. However, with this, that I said earlier, we cannot go through the metastasis. By using the combined with TRT, we can overcome by delivering the systemic treatment of radiopharmaceutical compounds, which we know exactly good for our patients into that. And this going to be cover the microscopic spreading of the cancer throughout our patients. And this also, once you use the TRT, can target it not only the localized tumor, but also can target the metastasis and some circumstance of the very small and very high hidden of the cancer cell. In the biology, as we know, it's a tumor microenvironment. First of all, with some of the drugs that we use nowadays in terms of chemotherapy, it's mostly targeting the cancer cell. But to keep the cancer growth, only cells cannot grow itself, but it provides some of extra to serve to help the environmental of the tumor to be exist and to be thrive. Therefore, we call as a tumor microenvironments, such as the vascular, such as the environmental behind the sum of filaments, some of cells that are supporting the cancer cell growth. So therefore, with the use of radiopharmaceutical compounds, we can specific and target to these components of tumor microenvironments. So we can be sure that cancer cells will die, and also tumor microenvironment don't serve the cancer to survive, so the cancer will die and no recurrence after the treatment. Therefore, seem easy. However, with the issues of radiation biology that we mostly concern is the, as I said, recurrency or the re-happening back of the cancer cell. This cannot be killed at the first time that we providing the radiotherapy. This is regarding for the resistance. But the advantage of the TRT with the continuous exposure of the low dose of radiations, we can provide the effect that we said, redistributions. With the effects of redistributions, the cells which is already first being in the S phase, which is a very resistant to the radiations, with the continuous exposure of the radionuclide therapy, the cell will move from the S phase, which is resistant, to the G2M phase, which is very sensitive to the radiations. So therefore, once we continue exposure in this phase, the cell will kill, the cell will die. And this is enhancing the better effects of radiations. And also with the radiopharmaceutical compound, we can bypass or we can overcome the hypoxic effect, because we know that with the low altitude radiations like gamma ray, is depend on very much with the oxygen. The sensitivities of the cell depend on very much with the oxygens. But when we use the targeted radionuclide therapy, which is conjugated with the alpha particles, emitting alpha particles, these high altitude radiations can not depend on oxygen. So therefore, in the tumor tissue where there is the heterogeneities of oxygen concentrations, if you expose the cell, the tumor where there is oxygen, that cell will die. However, we do expose the cell that has no oxygen or in the hypoxic level, that cell won't die. So if you combine EBRT with TRT, that emitting alpha particle, which is not dependent on oxygen level, so therefore your cancer cell will die regarding to that. And furthermore, we can conjugating our modifying our radiopharmaceutical compound or TRT with the radiosynthesization. Then this is going to bring up enhancing the biological effects of combined treatment, EBRT and TRT. So these three issues is kind of the starting the rationale of combined two modalities. Moreover, if we can, furthermore, the better and the things that we want to use this combination of modality is definitely because we want to reduce the resistance and the recurrency. If we can implement and if we can over the limitations of the radiations, we can have the better cell kill by using this technique of TRT. To overcome reduce the resistance for the TRT, usually we can use that for micrometastatic disease as well. And also for the EBRT, we can go with this idea of the overcoming of the resistance and provoke the limitations of the recurrency. Therefore, nowadays we have to look further how we get combining treatment, EBRT and TRT, how we can bring it for the new innovations in the field, in the era of the personalized medicine. As I said earlier, the cells have different biological patterns. The cells of each patient also have different biological pattern as well. So it's react to different way after being exposing to the radiations. In this combined treatment, we can looking for the theranostic approach. The theranostic approach, we can use the nuclear medicine for the molecular imaging. Okay, we can use CRT that not for therapeutics, but for the molecular imaging. This can be specific targeting to the tumor-specific biomarkers, and which is when we combine with EBRT, will we further implement and improve the critical outcomes. And to have the patient-specific optimization, I think this is a key message, is the optimizations. How can these combining modalities can allow the optimization for personalized medicine? These optimizations would allow by those customizations based on the tumor burden, based on the localizations of the tumor, and also based on the patient's tolerance or patient sensitivities to the radiations. Moreover, one thing that I need to show here again is the potential for the combine with the systemic therapies. When I say systemic therapies, we think about TRT, or we can also further combine with the another modalities like immunotherapy, like chemotherapy. So EBRT and TRT can enhance the efficacies of the treatment by using the systemic therapy, by increasing of the immunologically speaking, and also to improve the effect through the vascular effect. This is one of the things when I said vascular effect is one of the tumor microenvironments. So we think that we have one molecule VEGF, vascular epidermal growth factor, which is overexpressing in the cancer cells. So if we can combine the treatment, which is specifically target to the vascular system, so we can cut down the vascular, so we have no spreading of the cancer cells. Also, we have stopped the oxygen or nutrients to bring to the tumor, so we stop the growth of the cancer cell. Therefore, all in all of this rationale that I bring up to you, it can further broadening the treatment indications. Here I show here is the hallmarks of cancer. If we know as a biology, we know about the cells, we know the basic of the cell, we know the basics of tumor microenvironments. Moreover, we have to look for the hallmarks of the cancer, how this cancer can go, how this cancer can die by different molecular that can specific target. So in this sense, we can use it to advance our combined treatment of EBRT and TRT. So in here, about 6-7 rationales that I bring up to you, I think that the integrations of the EBRT can further, can maximize the tumor control, and also in this sense, with the reducing of toxicity, can further advance the cancer treatment. Therefore, in this way, even though combining EBRT and TRT offer very powerful in my feeling, I think is the future of the treatment. These still have, I think I see several opportunities of these combined modalities. So one thing for sure, enhance the tumor control. For sure, with this regarding to modalities can have synergistic effects and bring to Theranostics of the personalized medicines, and broadening the difference of the treatment strategies as I presented here in this slide. There's varieties of strategies, so we can bring up the therapeutics of the targeted radionuclide therapy with not only EBRT, but we can further combine with several of the techniques to advancement and to help our cancer patients. And moreover, this is slide I showed in here is some of the previous studies. Of the previous studies in the clinical studies, you can see here there are several of type of cancer that been used and been studied with the combined treatment of EBRT and TRT together. Some of the paper they use the MRT like molecular targeted radionuclide therapy, because for the MRTs for TRT we look for the specific molecule which is interesting for inhibit the tumor cell growth. So, and many of them is provoked from preclinical studies into the clinical studies. So with this time allowed, I would like to show you some of the studies. I think this is interesting. And in this paper, the studies, the combining EBRT with the lutetium-177 PSMA for the prostate cancer. And in this paper, they're starting, interestingly, from the preclinical, from the cells, and then from animals, and then study with cancer patients. So in this slide, they're using the PSMAs in 177s in combinations with the EBRT. So the doses we provide, if you're interested, I will not go into the deep detail about how they do the studies, but I would like to show you about the impressively result. In their result, they're showing that from this the slide here, the combined treatment significantly can improve the tumor control and the survival of the animals. And by comparing, they compare the monotherapies with no treatment in combinations with the EBRT and TRT. Is interestingly for EBRT can improve the survival of the animals, and also we can prolong the tumor doubling time more than 1.7 or about almost 3 times. This is impressively in terms of in the fields of radiation biology. If you can see the improvement of the outcome after using these modalities, and also for the EBRT can help to increasing the tumor uptakes by more than about 14%. By EBRT help to increasing the uptake of the TRT, it means that this can be better in the result that we observe. And again, with the higher uptake that we observe is showed up here in these studies, there has been calculated the tumor absorbed dose in the tumor in animal models. And here is very much clearly showed that they have a higher, even though it not significantly, but also clearly seen the increasing of the tumor dose, absorbed doses after combining treatment compared to the single modalities alone. With these studies, there are further studies into cancer patients. In these studies, they studies the effects of the gallium PSMA with the combinations with EBRT, and the studies have shown firstly use the 74-year-old patients locally advanced prostate adenocarcinoma, and with the N1, M0 stages. And with the treatment that they're providing, is interestingly, they provide with this scheme of studies with the IMRT, 45 grades, 54 grade for the prostate and 45 grade for the pelvic in 25 fractions. And combined with the lutetium-177 from the 3 cycle of the activities from 3 to about 3 to 6 gigabecquerel per cycle. And what they've seen is that they have found first patient that respond with the lasting remissions. What they have observed, impressively interesting as well, they found that from difference of the treatment that they provide to the patients, they observe the well tolerated with acute and chronic toxicities. So it means that the combining treatment of EBRT and TRT reduce the normal tissue toxicity, as I previously mentioned. And here they also seen that they have completely remissions that last, for 5 years. This is interesting for our cancer patients. And however, even though they have a long lasting about 5 years, they still found the relapse. They found that the new metastasis occur outside of the irradiation field. When I found it here occur outside of the irradiation field, it's bring me up back to the first slide that I'm showing to you, because the effect of radiation, they have not just targeted effects, but also non-targeted effects. The non-targeted effects regarding to the cells that have not been exposed directly to the radiation. Therefore, if they found the new metastasis outside the radiation field, therefore might be think that there are some of non-targeted effects occur. So this is another thing that we have to be concerned.
Right.
And this is kind of the challenge, This is kind of the challenge. We have been said that more you cell have been directly exposed to the radiation, more you can send the stress toxicity, stress molecules to the neighboring normal tissues, so that bring up more of the intensity of bystander effects. So everything beside the biological effect come from firstly dosimetry. So more you provide too much dose, either you got the cancer cell kill, but you also get the normal tissue toxicity via the targeted effects and non-targeted effects. So this is, I'm not expertise as Dr. Deni for the physics here, but it's my concern very much before I interpret whatever about the biological effects. We have to look for the dosimetry, and this is very challenging. As I mentioned earlier, for EBRT, it's well planned, but for TRT, it depends on the one by one, the kinetic uptake of our patient through the radiopharmaceutical compound that we use to treat. Therefore, in my feeling, this is a big challenge, how we can make the sophisticated dosimetric planning for combining EBRT and TRT. EBRT, you have to plan. For TRT, you also have to plan. But when you combine the two modalities together, how you mostly perfect fit to have not too much dose that you provide to our tumor and to tumor tissues and sparing to the normal tissues. And beside that, as Dr. Deni has been already presented, all the dosimetry regarding for the internal dosimetry is based on imaging. So first of all, got the image of tissues, image of bodies, image of cells. In my sense, we're looking for the biological dosimetry. We're looking not just for the whole organism, not only the big chunk of the tissues, what about the dose in there, but I'm concerned about each specifics of the cell, how much it can be absorbed from the dose of EBRT or TRT that we provided. So in this is one of the things, and I think it's very challenging, I'm not know how, what the thing is like for the biological effectiveness dosimetry. So we bring from the physics to the biological dose. This is one of things that I concern very much. Whatever you have to looking forward about the way of to plan your tumor patients, how you can do it, One thing that why I said is very challenging, because each of radiopharmaceutical compounds that you are providing to one particularly tumor tissues, which is heterogeneity in structure. So when they have a very heterogeneous uptake, they also have shown with the difference of the different heterogeneity uptake, they call non-uniformities, dose distributions. And these can result in the difference of the surviving fractions. More you providing, more the cell uptake, the activities, more the dose is being absorbed. Therefore, more the cell will kill there, more the cell will die. But in the sense, one other thing, I would like to bring you in this particular figure when we say that our drug, our radiopharmaceutical that we use, emitting difference of radiation. For beta, for alpha. Beta for the big size of the tumor, for alpha for the small size of the tumor to spare the normal tissues. However, not just think only that particularly part length of the radiations, but we have to look more about the way of the distributing. So when you see in this survival curve that presenting, you can see the pattern of the survival fraction from the uniformity uptake and non-uniformity uptake of these two particularly difference of the particles. You can see clearly there's a difference of this pattern. You can see that the delta alpha, the difference between uniformity and non-uniformity of the alpha much more than the beta particle. So this is the way that why I bring up to you. This is one of limitations of the TRT, because the heterogeneities, we have to look more about the dose that concern the heterogeneities, dose distributions, all right? And this, from this one, I would like to say that the distributions become more of the concern for the TRT, for the non-uniformities way of doing, okay? And this is one of the example when they do the those evaluations, biological effective dose, volume histogram. From these studies, you can see there are varieties, and this is the thing that you have to calculate very well about the EBRT and the EBRT combined with the TRT. Bring up to the dose is still the one of important, okay, challenging for me. But not just that, why the dose is also important, because more the dose we provide, more the toxicity will be occur. So the toxicity management is one of the challengings, all right? So the challengings is increasing, okay, more or less with the normal tissue, with the bone marrow, with the nephrotoxicities. The solutions, we have to optimizing the sequence. The sequence of and the dose of the fractionations of EBRT and the fractionations of the TRT. As the studies that I provide earlier, they use several fractions of EBRT in combination with some few cycle of TRT. And when exactly the good sequencing. The good sequencing coming up for my next challenging is the timing and scheduling. This one can need to be determined for the optimal timing for each of the modality. When you're gonna administrations of TRT and when you're gonna start the EBRT to have the maximum of the tumor control while minimize the normal tissue toxicity. So the thing is that we don't know by the theoretically, we don't know by the mathematically, we have to do the studies. And this brings another opportunity for you guys. If you like to do studies, we have to look further, and we require much more of the preclinical studies as well as the clinical studies that try. Okay, that try. Some of the studies that I presented earlier showed some of that varieties of the protocols and also showing up in several of the treatment outcomes. Therefore, fields of the challenges that remaining is that radiobiological uncertainties, like our patients have difference of the biological patterns. For some several of biological can bring up to unpredictabilities of the effects. So moreover, we have to look not just the targeted effects, but also look for the non-targeted effects. And also, we need further understanding of the synergistics as well as antagonistic effect. I would say here from the beginning to now, I always say that, oh, there is a synergistic effect of EBRT and TRT. However, there is not yet presenting, I'm not sure they're not yet present some antagonistic effect of the combined treatment. In this sense, some of these, when it's synergistic, when it's going to be antagonistic, is regarding as very much through the patient-specific variabilities. So this is we bring back to the patients that have several and difference of radiosensitivities. Also, tumor of each patient have specific of radiosensitivities as well. So moreover of this is we can further understanding and try to optimize the treatment outcomes. Okay, this is my point of view. And this is my point of view in these two more slides. This is my point of view, the directions and the future of this combined treatment of EBRT and TRT. So for myself, I think that some of the patients who cannot has higher dose of EBRT, on some of the patients cannot have only EBRT as a local because they have metastasis, so they need the TRT. So in this sense, we have to be really understanding what exactly the good and the bad and synergistic or antagonistic of the TRT combined with EBRT. The advance of the imaging. Advanced imaging can help us for overcome the challenges of heterogeneities, biological dosimetry of the combined treatment. This can bring us to the real-time dosimetry as well as to help us for the therapeutic guidance in terms of sequencing, in terms of optimal timings of this combined treatment. And also with the personalized medicine, we can further look ahead for the biomarkers, which is specifically for each patient, specifically to their sensitivity to the radiation, to help us to predict and to monitor the response of the combined treatment. All in all, preclinical study, we need it definitely, but also clinical study, we definitely need it for the further implemented in the reality of the clinical practice. So in this sense, I would like to share you around here about the way of, we think that molecular imaging, dosimetry, and biomarker, and way of synthesis of the drugs, as Dr. Shuichi said, to bring up to at most as possible theranostic, ideally as possible for the therapeutics of the radiation with the maximum dosimetry. Dose to the tumor and normal tissue have as less as possible the toxicity. So we have to look for the optimized treatment schedule to the practice that we have to looking for in the future. And therefore today, in the conclusions, I will say that the EBRT with the TRT can bring up the very much interesting for the systemic integrations for the better outcome, for a further outcome, for the quality of life, for the long-term survival for our cancer patients. And definitely I would say this is a way of research that we're looking for. And however, for the one of the 30 seconds key takeaway, as a radiation biologist point of view, for the combined treatment can bring up for the complementary approaches of EBRT and TRT for the systemic disease, for the metastasis disease, as well as for the local tumor. And this can enhance the tumor control, can reduce the recurrency of the cancer by reducing the toxicity, bring to the personalized therapy, and bring up for the mostly the clinical applications to advance metastasis and resistant cancer. Furthermore, we need very much the advance of imaging, advance of the biological dosimetry, as well as the personalized, individualized radiopharmaceutical compounds for these combined protocols. So very much appreciate your attending, and thank you very much for your kind attention. Thank you so much. Thank you.
Well, well, thank you very much for your wonderful talk, Dr. Thititip, regarding the to explore the combination of the treatment between the external beam therapy and targeted radionuclide therapy. I think this one can explore the point of view to the participant to the novel treatment in theranostic to combine the external beam therapy and for the theranostic radiopharmaceutical. Yeah. So that's all of the lecture from our honored speaker. So it's time for for the Q&A. So I got a lot of the question from the participant. So let's start first. Well, this question may be for the Dr. Shuichi regarding for the radiopharmaceutical production. But I think
Yes.
you already answered the question, right?
Yes,
Regarding
in the
the
box.
key challenge in large scale production, radiochemical stability and labeling efficiency of the terbium-166, and how to do this impact is routine integration into the clinical radiopharmacy. So Dr. Shuichi, you would like to expand this answer again to the participant?
Okay, thank you for your the nice question. So I will answer one by one quickly. For the first one, the capacity of the terbium production is depend on the nuclear reactor. So to increase the the production, I should recommend to, the effectiveness of nuclear reactor. In my best to my knowledge, there are just only two sites of production in the world right now. One is in Netherlands and another one is in Israel. So you can contact your distributor about this issue. For the second point is the radiochemical stability. So in my experience, I have not labeled terbium 121, but I believe that this is very similar to lutetium-177. So as the stability I found in lutetium-177 radiopharmaceutical is about 4 to 5 days, that keep in refrigerators and avoid the light. So the quality is still good until 4 or 5 days after labeling. And also the third point is labeling efficacy. Yes, similar to the second point. Normally I do the radiochemical purity more than 98%. With the similar property of lutetium and terbium, I think the radiochemical purity might be similar. And for the last point, just a moment, please. The impact to routine integration, this is really important, and thank you for this point. In my opinion, we need to choose the patient very carefully, because terbium will be very good for the micrometastasis. So I think, for example, when the patient treat in 2 or 3 cycles, and after we evaluate, we still find a very small tumor mass. In this case, terbium might be better than lutetium.
Mm-hmm.
Yes,
okay.
I hope I can answer your questions.
Yeah. Okay. All right. Thank you. So I have a question for you, Dr. Shuichi, regarding for the terbium. So are there any criteria for the treatment? So because I think most of the treatment right now go with the for the lutetium, right?
Right.
And are there any criteria to this patient should go for the lutetium, this patient should go for the terbium treatment, and this patient should go for the actinium 225? Yes.
Thank you. Yeah. In my center, after we treat for 4 cycles, we evaluate by gallium or fluorine PSMA, and then we decide in the in case of the the evaluate result is certified or is good enough, we can continue. That means the patient still responds well with the lutetium. We can continue the dose, the 5th, 6th, and 7th dose. But in the other hand, when the patient response is decreased, this can be concerned as the sometimes the real difference is cancer can produce a specific enzyme to connect the DNA damage. In this case, we concern to change to actinium-225 because the alpha emitter have a stronger power to cut double-strand DNA. This is what is our practice, but the actinium-225 have a limited for the availability from the production side. So in this case, we might concern terbium as the alternative.
Okay, and well, just quick one. So, how do you think about the trend? So, in your point of view, how about the trend like for the terbium in the future?
Yeah, the trend of terbium will be should be good if the price of terbium is going down, because right now the price of terbium is over actinium-225. So yeah, I think in this few years we still use lutetium and actinium as a main, and in the future terbium might be interesting, and moreover actinium astatine-211 is coming.
Oh yeah, for the astatine and
Right.
I think right now
yes.
in some country already start
Right.
using for the astatine, right?
Mhm.
Okay, thank you very much for your
Yeah, you're welcome.
wonderful answer the question. So I think we have the question for the Dr. Deni regarding for your presentation for the dosimetry. There are many questions come to you, Dr. Deni. So I will select some question. Well, since the accurate dosimetry often require multiple imaging sessions and extended patient time in the clinic, like give the burden to the patients, how can we make this the process more practical and patient friendly in routine clinical practice?
Yeah, so I directly answer it, Kitiwat, or?
Yeah, you can answer the question. So
Thank you very much for the question. So I think it's a very important and also interesting question, yeah, because the problem right now, why people tend to feel not so good to performing dosimetry is because we need to perform a lot of imaging session, right? And for example, as EINM in one of their guidelines saying that we need at least 3 time point for having a good estimation of the absorbed dose using monoexponential function, for example. So that's why reducing the number of the data is very, very interesting, yeah, for many people. So that's why this is where the single time point dosimetry come up actually. So of course, if you can imagine, so it is like just a curve fitting, yeah. When we want to have the curve, then at least if we have it linear, at least we need to have 2 points, right? So there is a very basic mathematical concept. But how can we get a very good shape of the curve by only having one dot, one data? So that's why it's very, very difficult to do. So that's why, for example, like Hardiansyah, they assume monoexponential, and they assume actually that the clearance of all people, the way of the kidney clear the drugs would always be the same. So then they just need to scale it up and down. So that is how the Hardiansyah work. For the Madsen, for example, they assume that, okay, this value may be different, but we can calculate it from the population. But we can actually directly use the population data itself in the fitting, as I mentioned in my presentation, by performing population-based pharmacokinetic modeling. So that's why this is one of the way people would like to do dosimetry in the future, hopefully, because if we actually it's already shown that the result is quite good, but it's shown only for several center data. So that's why we need to perform more and more study in different places, in different center of data and so on. Then in one point, I think then people can believe more on this method, then people can implement it, yeah. But there is a solution for this multiple imaging problem, and one of them is single time point, and it is plausible. We just need to check more on this. Yeah. Okay, Kitiwat, thank you.
Yeah. Okay. So yeah, you mentioned about for the second time point dosimetry, and then we need to collect more data. So I think second time point dosimetry now is more interesting in order to reduce the burden for the patient and also for the scanner, and more comfortable for the patient and also staff and the scanner.
Yeah.
So based on your experience, so because we acquire like multiple time point, right? So in your opinion, and based on your experience, so which time point is the best one or suitable if we would like to select for the second time point dosimetry
Yeah.
to
So as
acquire the data?
Yes, as I mentioned as well, Kitiwat, it depend on our aim actually, because for example, we perform always study with the threshold of 10%, Kitiwat, usually. So
Okay.
we say that, okay, so if the error, let's say that our single time point dosimetry can mimic the full time point dosimetry with multiple imaging with the error less than 10%, then we can use it. But actually, it is a question to be answered by the community. Why? Because one of the publication at the GNM from Gomez et al., they said that 27% is also acceptable. So, so it's quite interesting because they found that the maximum error is 27% from their method, and they claim that 27% is still okay. So that's why we can perform at any time point, gitu, you can imagine. So even at 2-hour post-injection, this imaging at 2-hour post-injection can be used for STP, but the error is 27%. But we need to be careful, this is just the mean of the error. But if we calculate individually, there is a possibility that we have a very high error of in certain patient. So that's why this is something that need to be, we need to have a consensus. What type of error that we can accept? Yeah, so for example, my result with machine learning on population-based pharmacokinetic modeling, for example, we show that the maximum of the mean error is 16%. So we say that it's quite good enough if we compare it at least with 27%, right? So, there is no consensus yet about the error that acceptable, yeah. But the best time point, if we use 10%, then usually for lutetium PSMA is around 42 to 48 hour post-injection. Yeah.
Okay, all right. Thank you, Dr. Deni. Yeah. So more question to you, Deni, for the dosimetry. The question is about since the factors such as partial volume effect, patient motion, and comfort, patient comfort during the imaging can significantly impact the dosimetry accuracy. What the strategy that you would like to suggest to minimize this uncertainty in the clinical practice?
Yeah. Okay. Uncertainty is also a very important concept, yeah, in dosimetry, and hopefully more and more people aware and also calculate this, because ENM has already a guideline showing about this, and hopefully people also calculate it, even though many people tend to focus more on the accuracy, not in the precision. But yeah, of course, we have the uncertainty in the data, but this error of the uncertainty in the data will be propagated during our calculation of the absorbed dose. And in the end, we can also model it for calculating the precision of our absorbed dose. And of course, there are some, there is no freelance. So if we decrease the number of the data, of course, the precision is getting lower, the accuracy is getting lower, and so on. If we also have another study showing that if we add more, for example, 2 time point, then the accuracy is increased, precision is also getting better, and so on and so on. So if the question is again the threshold, the answer is still the same. We don't have the consensus yet. But how we deal with that, so it depends. So if you want to make it better, then you need to add more data. So there is no freelance again. So for example, if we have one patient, we would like to have a very precise and accurate result. So we don't have to perform many imaging from this patient, but we can borrow the information of other patient in the population to help this patient to get the absorbed dose, for example. Or we can also measure another types of data, for example, like the biomarker. From our machine learning result, we show that the biomarker of the patient can also help, to better predict the accuracy of the absorbed dose. So again, if we can have more data, then it's good. But if not, then at least the data that we have, it depends on us what threshold that we would like to have in our calculation.
Okay. Yeah. Thank you, Deni. And just quick question. Like, did you already implement like the dosimetry for the treatment planning in your center?
Unfortunately not. It is very challenging. So
Yeah.
all of my data was coming from my colleague. So actually we perform iodine 131 dosimetry, we perform lutetium PSMA, we perform lutetium dotatate from all of my colleague in Europe. But unfortunately, we don't have yet the data from our country. So
Yeah.
I mean, go into that direction. So and you Kitiwat, we also collaborate and so on. So it's quite challenging, but hopefully in the near future we can.
Yeah, right. Just hopefully in the near future. Yeah, just to share to you and for all participants. Actually in our center at King Chulalongkorn Memorial Hospital, we have the treatment planning for the lutetium 177, and we calculate the dosimetry. Yes, for those who interest, like to visit, we are welcome. Yeah, for this. Yeah. And also for those who interest, you can ask Dr. Deni for the collaboration as well. Okay. All right. So let's move to the next question. This may be for Dr. Thititip. Yeah, it's your time. Okay. As you mentioned, combining dosimetry of the EBRT and TRT, for the targeted radiotherapy are challenging as your talk. Would you like to share the dose tolerance for the normal tissue if we treat the patient with these combined two methods? Yeah, what about the tolerant dose for the normal tissue? Yes. And right now, are there any reference or publication about this?
Okay. Yeah, it's a very great question. Thank you very much. So if I answer this question, I would say another 30 minutes, I think, because it's I'm surely there is not yet universal protocol or the well-defined protocol in combining of this EBRT and TRT yet nowadays. But I think it's like, I would like to say it's like, this is the way that we can see together, how we can practice together, how we can look together, how we overcome this challenging. Like I said earlier, suggest earlier about the solutions, we have to look very well about the dose. So we have two doses, right? Dose from EBRT and the dose from TRT. I would say if the dose that we have to look and save for the normal tissues, we have to look for the dose tolerance for sure for the organ at risk, which is we have to firstly look these two modalities in one. So it means that you look the summations of the dose EBRT and the ones of the dose TRT into one. And therefore, you can look at the total dose and see that the tolerance dose to normal tissues can be accepted. For example, you can convert it TRT, as I mentioned, to a biological effective dose using the linear quadratics models. And this can go for the dose or radiation dose. And this we can go for that and pairing this, the BED, biological effective dose, with the EBRT planning. And this you can have the summations of the combined modality. And for we have the combined treatment dose. Now we have looked further about the dose, tolerated dose for one of the key normal tissue, for example, for kidney. We know that for EBRT, approximately we have the dose about, you have to keep at low about, I think, 20, 18, 15 grade, I think, for the low risk of the kidneys, the toxicity. And if you look for TRT, we have to look a little bit more for BED, biological effective dose. Sometimes we look a little bit to 20 or 25 grades. So in this sense, if we combine together, we have, let's say, I would say, this is my opinion, I would like to ask also the expert, Dr. Kitiwat and Dr. Deni, about the dosimetry, okay? Well, how we can define the exact dose of this, okay? So it's good, that would be a great thing to summations of the dose for spare the normal tissues. And another thing that I would say, for when you use targeted radionuclide therapy, you have to concern not just nephrotoxicity, but also looking for the hematotoxicity. This is regarding for the, the emitting of the radiation that we use, like emitting from the TRT. We have to look for the bone marrow toxicities. Like for TRT, we have to, for Dr. Shuichi said, we have to look for the alpha particle to spare the bone marrow toxicity. But for EBRT, also have a plan. Okay, we have other plan like IMRT, which can spare the bone marrow sparing normal tissues in this sense. Or we can use for EBRT, we can think about not just only for LINAC, but we can use EBRT as a proton therapy. So this is another way that we can spare of the organ at risk and avoiding the normal tissue toxicity of combined treatment. I would say shortly about this. Yes.
Yeah, that's right. Yeah, Dr. Deni, did you have
I have one comment. So
Yeah.
I completely agree with Dr. Thititip, yeah. And this is actually the goal in the future, especially in nuclear medicine, if we can create something like a theranostic digital twin. So the possibility to do this is by, for example, using such a physiologically based pharmacokinetic, because one of the most important thing about digital twin is how we can mimic really what happened inside of the patient, how the dynamic information of the patient, how they change, the blood flow, how they change, how the volume, how they change, and so on. And then we can add it all together in such a model. And then we can always update it. So there should be an interaction between the model and also the patient. It means that the model will give information to improve what happened in the patient, and the patient will give data to the model to be dynamically updated. So again, about the question whether we need to have those current and so on. So I think, one of the way in the future is the digital twin, because with this digital twin, we can always update it after the ABRT, for example, then all of the physiological parameter, the information about the tumor and so on will be changed, right? And we can update our model. We can, again, make a simulation to improve it. And then after that, for the second cycle, we update it again. So this is hopefully can be achieved.
Yeah, in the fields of biologies, we look also for the, not just for the, macroscopic view. We look a little bit smaller in terms of a microscopic view of the dosimetry. So if in the future, we can get to that ideal microscopic dose absorb dose in particularly each of the segment, each of the component of the tumor microenvironments. That would be help us very, very well to clearly see the prognosis, monitoring of tumor response. I think it's a way to go. Is another challenge.
Can also be added. I agree with Dr. Thititip. We can be also added to our PK with the PD model, and it's already show actually. For example, how the tumor is growing, how the tumor is shrinking, and so on. All can be. But of course, it needs some effort. It needs some collaborative. Study and so on.
We need collaborations.
In the future, it will happen. Thank you, Dr. Kitiwat.
You very interesting comment from Dr. Deni. Like I think right now digital twin is more interesting, and this is the new trend in theranostics. In some region, for example, I think in the US, they already kick off for this project regarding for the digital twin, right? Yeah, but I'm not sure how about in the Europe. Yeah, I don't know about that. And hopefully in the Asia Oceania region, like and also in Southeast Asia region, hopefully we will start for the digital twin project soon. Yeah.
Very nice.
Yes. Well, Dr. Thititip, one more question. You said that right now there is no standard protocol, I mean, to combine between the EBRT and TRT. So in your opinion, should we start like from the EBRT first or from TRT first, or it doesn't matter?
Yeah, this is another challenge that Dr. had to bring another big questions. Yeah, in the sense like if you think about basically the combined treatment back to the basic like radiotherapy plus chemotherapy is also big questions for neoadjuvants or the concurrent combinations or post combined treatment, so when exactly chemotherapy you provided in terms of the, dual modality. So before, during, or after. So this is another way of, speaking out. But I think it's like, if it may, in some of the research that have shown that EBRT helped very much in terms of increasing of the radiopharmaceutical uptake in the tumor cells. So in this sense, EBRT might be increasing the tumor box vasculature somewhere, and this will be increasing the perfusions of the radiopharmaceutical drugs into the tumor cells. And this may be more of the advantage of increasing of the dose absorbed dose in the cells. So in this sense, like you EBRT first and then TRT. And some of the several of the research have been doing in these ways, like EBRT first and then TRT. But in a sense, like they always says like some have observed synergistic effect, but some have seen like additive effects. It means either modality have exactly the same outcome. But not regarding to my studies, not yet have been studies reflecting the antagonistic effect. So one is another, I think is a good way to go, like combined treatment. It give us the advantage, give us the better way to go to improve the clinical outcome to our patients. So the combined treatment if we can find the right, the right pharmaceutical drugs, the right time of treating, and the right sequencing, I think it's going to be further way of helping our patients.
Okay, yeah, thank you so much. Thank you so much, Dr. Thititip. Well, for your very clear answer. Well, are there any questions from the audience? Yeah. So this is not the question, just the sweet words to the speaker. All of your presentation was highly informative and delivered with great clarity. Yeah. Okay. Yeah, an excellent and informative lecture. Many thanks to Dr. Shuichi, Dr. Deni, and Dr. Thititip.
Thank you. Thank you very much.
Yeah. Okay.
Yes, thank you.
All right. So I think if there is no more question, I think it's time to close the session. But last but not least, so again, I would like to thank all of the invited speaker, Dr. Shuichi Shiratori, Dr. Deni, Hardiansyah, and Dr. Thititip Tippayamontri for giving and joining us and giving such a great lecture to the participant today regarding for the refining Theranostics in the era of the precision oncology. Your talk gives such a very informative to the audience. We have the topic cover all of the point of view, starting from the radiopharmaceutical production in Theranostics, the new trend of the radiopharmaceutical, and then the dosimetry in Theranostics, which is very important. And then the last one for the point of view from Dr. Thititip regarding for the radiobiology by combining the two methods of the EBRT and the TRT. Yeah. So and I hope that all of the participants will gain a lot of the knowledge from our invited speaker today. and hopefully we will have the next episode in the near future for the Theranostic again. Yes. All right. So thank all of the participants and hope to see you all for the next episode. Okay. Have a good day. Thank you, everyone.
Thank you,
Okay,
Kitiwat.
thank you.
Thank
I would
you.
like to
Thank
thank
you.
on
Bye.
behalf of AFOMP, all of you, for this wonderful comprehensive webinar on this Theranostics. Thank you very much. And looking forward to see you all on 30th August for the Industrial AFOMP webinar. Thank you. Thank you, everyone.
Okay. Thank you.
Okay.
Thank you very much.
Bye-bye.
Thank you.
Have a good weekend. Okay.
Thank you.